afternoon, everyone. I'm Anupama Rajesh, and I'm honored to moderate this session for People and Planet United. Today, we are discussing a significant challenge in hematology, higher risk myelodysplastic syndromes, or HR-MDS. HR-MDS are bone marrow cancers, and this is a disease area where patients urgently need new options that are both effective and manageable for their specific health needs. Joining me are two experts who are deeply involved in this mission. Dr. Brian Ball is an assistant professor in the Division of Leukemia at City of Hope, California. As a specialist hematologist oncologist, he focuses on higher risk myelodysplastic syndromes and acute myeloid leukemia. A dedicated clinician scientist, his work centers on developing translational and personalized treatment approaches to improve patient outcomes. Dr. Ball leads several investigator-initiated clinical trials exploring novel combination therapies for relapsed refractory MDS and maintenance strategies following allogenic stem cell transplantation. His significant contributions to the field have been recognized with ASCO Young Investigator Award, the K-12 Career Development Award for Clinical Oncology, and grant funding from the Aplastic Anemia and MDS International Foundation. Furthermore, Dr. Ball is a CIB and MTR paid scholar and serves as a site representative on the NCCN Guidelines Committee for MDS. Welcome, Dr. Ball, to the session.
Thank you.
Joining him.
Go ahead. Sorry.
Thank you. Joining him is Dr. Petri Bono, the Chief Medical Officer at Faron Pharmaceuticals, a global clinical stage biopharmaceutical company focused on creating innovative cancer treatments that leverage the patient's own immune system. Faron's lead asset, bexmarilimab, is a first-in-class anti-CLEVER-1 antibody and is currently being investigated in phase 2 clinical trials as a potential therapy for patients with hematological cancers like HR-MDS in combination with other standard treatments. Welcome to the session, Dr. Bono.
Thank you. So glad to be here together with Dr. Brian Ball and really to discuss about the high unmet need in the higher risk MDS. And I would like to start by asking Brian, because MDS may not be so familiar disease for the audience, that what type of disease is MDS?
So thanks for inviting me to this discussion. Simply put, myelodysplastic syndromes, or MDS, are a group of rare blood cancers where the bone marrow fails to produce enough healthy, functioning blood cells. And when the marrow cannot produce these cells, the patients suffer from low levels of red cells, white blood cells, and platelets. And this leads to significant symptoms, including excessive fatigue, frequent infections, and easy bruising or bleeding. And of most concern, about 1/3 of these patients, these high-risk MDS patients, develop a more aggressive blood cancer called acute myeloid leukemia, or AML.
Okay, and what about what's known about the pathogenesis, about the drivers, and how common is this?
Yeah, so this is primarily a disease associated with aging. While it is rare in the general population, the incidence of MDS increases tenfold among those who are 70 years and older. As our population, our global populations, continues to age, we expect that the number of cases and the overall burden of this disease to rise significantly. And so it is a challenging disease.
Yeah. What about there's also an entity called therapy-related MDS, and now when cancer patients are treated better and better with various agents, so is that also increasing?
Yeah, about 10 to 20% of MDS will be a therapy-related MDS, or MDS that arises from prior treatments for other cancers. And as the cancer burden is increasing, we do expect that the number of therapy-related MDS will also increase. And this is a significant challenge as many of these patients will have worse outcomes.
And what's the current prognosis for these patients with higher risk MDS?
So the outlook for high-risk MDS is unfortunately quite challenging. The median survival is typically around 18 to 24 months. While a stem cell transplant is the only potential curative approach, it is an intensive procedure, and not everyone is a candidate for it. At least at our institution, we do not exclude patients on age alone, but older patients tend to have more comorbidities, and this excludes patients from transplant. And as a result, only about 10% of patients proceed to transplant in registration studies.
And if I read this correct, so patients who fail the standard of care, the hypomethylating agents, so the survival is just about 5 to 6 months. And to me, as a medical oncologist, so this is like actually so as low number as we see typically in metastatic pancreatic cancer, for example.
One of my colleagues, Steve Foreman, is calling it that. He says MDS, AML, or the pancreatic cancer of as in terms of prognosis.
Yeah, certainly. And I guess there are different means nowadays to categorize a little bit patients so that we can predict their prognosis better. But clearly, based on this discussion, when referring to almost like pancreatic cancer in hematology, so there's a very high unmet need. So where do these current therapies fall short at the moment?
So the standard treatment involves hypomethylating agents, azacitidine or decitabine. These patients have transformed care. For patients with MDS, they've been approved for the past over 20 years. However, half of the patients do not respond to these therapies. And for those that do respond, approximately 80% will have disease recurrence within 1 to 2 years. Once hypomethylating agents fail, outcomes are particularly poor, with overall survival of around 5 to 6 months.
Yeah, and these HMAs, azacitidine, so basically, at least azacitidine was approved almost 20 years ago to treat this disease as standard of care. And isn't it so that there's been quite little progress, except for some rare subtypes of higher risk MDS, but for most of the patients, the treatment has been quite similar during the last 15 years or so?
Yes, unfortunately, we've had many clinical trials to try to improve upon the standard hypomethylating agent treatment, but these have not been successful. And so it remains the standard of care for high-risk MDS.
Why has it been? There's been several failures in phase 3 trials with good candidates. So why has it been so difficult to get progress with novel agents in this disease?
So I'm sorry, I guess I'm reading your part then, Dr. Bono. I don't mind doing that, but I'll go. So the challenge lies in the biology. So high-risk MDS is fundamentally different from other blood cancers. So historically, many experimental treatments focus on trying to directly eliminate the cancer cells. However, because these patients are often medically fragile with cytopenias that have significant symptoms, these approaches can be difficult to tolerate and don't always provide lasting benefits. And so we've realized that we needed therapy that works through a completely different biologic mechanism.
Yeah. So, and I guess elderly patient population toxicity of the treatments probably have been also an important part and challenges why it hasn't been so easy to get success in this treatment group. And there are luckily some new ways how to tackle this disease, and I guess one of those is a novel investigational agent called bexmarilimab, and it's a novel checkpoint inhibitor, or actually macrophage checkpoint inhibitor that reprograms the bone marrow immune environment, so tackling the higher risk MDS in a completely different way. And this is the asset that our company Faron Pharmaceuticals is developing at the moment in phase 2 trial, and really here shown the mode of action. So what is the mode of action is that actually it's removal of the immune suppression in the tumor microenvironment there in the bone marrow. So reprogramming suppressive myeloid cells towards immune activating phenotypes, and not just as typical checkpoint inhibitors. This has also a direct other mode of action, and that's a direct effect on the cancer cells, the blast cells, which are all positive for the target, for the Clever-1. So they express Clever-1 on the surfaces, and with this anti-Clever-1 antibody, we can not just increase antigen presentation in the tumor microenvironment, increase T-cell infiltration, but also sensitize those blast cells to the standard of care, since we are disturbing the mitochondrial oxidation and making them more sensitive to standard of care, such as azacitidine. And since this is a novel type of immunotherapy, so this is not cytotoxic agent and better tolerated than traditional chemo, and meaning that there's a possibility to increase the efficacy since the toxicity when adding something on top of AZA shouldn't be an issue. And actually here we can see results from the trial, from the BEXMAB phase 1 and 2 trial, about the side effects in that trial. And actually, I would like to ask you, Brian, that you've been and your site, City of Hope, Comprehensive Cancer Center, has been a very active site in enrolling patients and treating patients in this trial with bexmarilimab. So how do you see these numbers that compared to the gray bar azacitidine alone, the blue bars bex-aza actually seem to have less neutropenia, thrombocytopenia, anemia? Is this something you have noticed when treating the patients? Does these overall results, do they reflect your clinical experience with the patients?
Definitely, it does. I mean, I think that's one of the reasons that I'm so excited about this combination, in that it seems to be improving the blood counts as well as controlling the disease. And that's a very promising shift in strategy. Instead of using more intensive interventions that might further stress a failing bone marrow, we are looking at how to make the environment itself more effective at fighting the disease.
Yeah. What about then the last bar there, treatment emergent adverse events leading to AZA reduction? In many trials, actually, the tolerability issues have caused dose reductions for this AZA backbone, meaning that the relative dose intensity of AZA has been reduced quite a lot, and therefore then the combination may not have been that successful. So what do you think about this? It seems that bex-AZA actually doesn't increase AZA reductions for the patients.
I think that's very promising. given that azacitidine is the the backbone, the only standard therapy we have for this disease, and we know that being able to give more consistent doses improves survival outcomes. That is important that we're able to give the standard dosing without dose reductions.
Yeah. So there's promise in targeting immune resistance and targeting directly blast cells that are positive for the Clever-1 target to develop that as a new treatment for higher risk MDS, and I guess in the phase 1, phase 2 combination trial, we've seen clinically meaningful response rates. Actually, in the front line of treatment, 9 patients, 85%, and then favorable looking tolerability in this frail, difficult to treat elderly, high risk MDS population. And we didn't go too much into details about the efficacy results, but there's been also a median survival of 14.5 months in these relapsed and refractory MDS patients, where the historical controls provide that 5 to 6 months benefit approximately. And that's why we feel that this immune reactivation or removal of the immune suppression may eventually help to improve the outcomes of the HMA therapy, and really also for those pre-treated patients who have failed HMA to overcome the resistance. And of course, this remains to be shown in a randomized setting, because in this trial we have treated in a single arm setting. But overall, about the efficacy, so how would you comment on what's your personal patient experience with the drug, and when moving forward towards a phase 2b randomized trial? So what expectations do you have for the trial?
I have had great experiences with this agent. I think what is most promising to me is that it seems to be active in very high risk populations. So particularly among those with these therapy related types of MDS that have P53 mutations, the highest risk disease that we deal with. We're seeing response in those patients that is similar to responses among those who don't have those abnormalities. And so I think that is an area that is very exciting for me. And I think the other thing that we've seen is the remissions are quite deep, and we see clearance of mutations and other cytogenetic abnormalities. And so that to me is something that I think provides further support for the phase 3 trial.
Thank you. That sounds good, and really looking forward to moving this Bexmarilimab forward to the registrational trials, and we are aiming to get first patients in to the phase 2b trial by the end of the year from US, and including also your site, City of Hope Comprehensive Cancer Center. And in addition to US sites, so we're planning to have a trial open in UK, and then in several also European countries, really ultimately to improve the patient care for these higher risk MDS patients, where the unmet medical need is high at the moment. And of course, there's a lot of excitement in the field since immune resistance is under addressed driver of the disease, and probably tackling a bit more than chemo, actually the root cause of the disease. But of course, that remains to be shown in the upcoming trial. And really, as you mentioned about these patients, elderly, fragile patients, so it is really relevant to provide effective treatment that minimizes the harm and leads to clinically meaningful benefits for the patients, like less anemia, hopefully less neutropenia, less infections. And of course, the results of the upcoming trial remains to be seen. of course, a lot of excitement to get that started by the end of the year. And really, Brian, I'd like to thank you and all your everyone in your site for being so active to develop this agent further in higher risk MDS. And now the journey just continues, and really the ultimate aim is probably same for every single physician, to treat patients better and help them to live longer. And this is actually what we're trying to achieve. Any other final comments you would like, based on your experience, Brian, here at the end of our discussion?
Yeah, I mean, as a clinician, I would emphasize that our goal is to find biologically relevant and effective treatments that minimize harm to really an already struggling bone marrow in MDS. And so, this is an exciting treatment.
Thank you so much.
Thank you, Dr. Ball and Dr. Bono. Thank you so much for this very, very insightful and interesting conversation, especially with respect to a molecule which seems to be entering a field which has not seen any movement for nearly 2 decades now. Thank you so much for this session, and we look forward to more discussions as we move this drug further into its developmental pathway. Look forward to more news from City of Hope and from other sites which will be involved in this. Thank you. Good afternoon, everyone.
Thank you.
Thank you.